Welcome to another episode of Dr. Doctor, the award-winning radio show and podcast featuring your physician hosts, Dr. Tom McGovern
and Dr. Andrew Mullally, where we and our guests discuss relevant and health-related topics from an authentically Catholic perspective. Dr. Doctor is brought to you in part by the generous underwriting of CMF Curo. Learn more at mycatholichealthcare.org and live your Catholic faith in your healthcare with CMF Curo.
Today, our guests will be heard across the EWTN Global Catholic Radio Network. In the first half, pediatric endocrinologist Paul Hruz returns to the Dr. Doctor microphone to tell us about transgender individuals in sports competitions. For our second half, plastic surgeon Oliva appears to tell us about the surgical procedures that individuals are undergoing to try to appear like the opposite sex. I just couldn't resist the unique opportunity to interview both of them at the 24th International Congress of the Federation of Catholic Medical Associations, which was held literally across the street from St. Peter's Square. So, Andrew, how does these interviews, not this interview, expand the prior interviews we've done regarding gender dysphoria?
Yeah, I think it was very enlightening. I wish I were there, actually. Haven't been to Rome in many years, so that would have been cool. But I really enjoyed listening to the interviews, mainly because Paul talks in depth about how it's not just testosterone. I think everything you read online, you always hear the Olympic Committee and stuff, testosterone-centric. There's a lot more to it than that. So that was news to me. And then as far as Al with the surgical stuff, I mean, you know, it's sad. It's crazy. To me, how many people do they have to practice on doing these crazy... I joke about that sometimes, like, oh, I'm glad I wasn't the first one, to get the Gomco practice on them for circumcision or something like that. But this is still something that is so odd, it's unnatural and imperfect. And with complication rates as high as 70%, urethral stenosis, he mentioned.
Yeah, you're going to hear about that. Urethral.
Yes, I'm sorry. Yeah. When you have numbers like that, this is something that's not a good surgery still, just from a surgical standard. So this is ongoing, really, experimentation is what I would call it in surgical, I don't know.
Mutilation.
Yeah, this is just, it's like a horror film.
Yeah, it's taking a body and making it what it isn't, which, of course, I think that idea could only come from the depths of hell, because for hundreds of years, human beings have apparently not thought of it.
Well, it's the opposite of restorative anything. There's nothing that's being restored. There's something that's trying to be taken down and built up differently in a way that we think is better than it was originally built. And it turns out we're terrible at it, just from an objective standpoint.
Yeah, no wonder, because it's not the way we were meant to function. And you use the word restorative. The meeting I was at, the theme is medicine transformative or restorative? And that's why these were two of the speakers, and they did an awesome job there. And you're going to hear another interview in another episode about a different aspect of transformative or restorative. And sometimes transformative is good when there's something lacking.
Right.
It may seem, and so we'll get more into that with these sets of interviews, though that's probably not the case.
Well, that's always the question. I mean, I don't know if anybody sits down and asks it or if they think about it before they start a career in medicine, but what's the purpose of medicine? The purpose of medicine? Is it really to improve or change or alter, or is it to, I don't know, alleviate suffering, which is kind of what I thought it was for.
Or healing, or making people whole, but not making them a cyborg or what's the word? It's almost a parody of what a human being is.
Well, and you hear about these grotesque things that the Nazis would do to people, right? Jewish people and other folks that they were doing these experiments on. And that was one of the things that came to my mind listening to especially to the surgical techniques, is that you can't, even if somebody says they have informed consent, you can't get informed consent regarding these surgical things. People don't have any touch tone as to what that actually looks like, not only because it's so uncommon, but it's also so experimental. A 70% complication rate. What about these folks who are attempting this even before whatever the age of consent? You pick an age, and I'd argue with you. There's not a time when you can give informed consent for this. And so that would be my biggest beef as well, is that this is really just a sick experimentation on people who are vulnerable. They're suffering, really.
Oh, and these people are suffering. And what all people are looking for is to be healed of suffering, and they're seeking love. And, the question is, are these transgender athletes, that's half of the interview, and these, women trying to look like men and vice versa, are they really finding love through this? I mean, I think that's their goal. I mean, yeah, they want to be happy, but we're typically happy when we fulfill our being, and our being yearns to be united with the beloved, and there is an appropriate beloved for a human being.
Well, yeah, that's exactly it. I mean, I think it makes me feel a little bit like, we're talking about the snake oil salesman that it's kind of depicted in the 1800s, going around in one of these carts. Just take this little potion number 9, and this is going to fix your problems. Except this is not just something that you swallow, you ingest, and it's all over. This is a lifetime of permanently altered physical function, appearance. Right. So really, I think vulnerable folks are being sold up a river. We really should do a lot, whatever we can, to stop this.
Yeah, you can't go backwards. That's why sometimes I have patients, they have a hole on their nose after removing cancer, and they're not sure if they want me to do the reconstructive surgery to put it together. And I always tell them, look, if you're unsure, don't do anything. And if you don't like the way it looks, then you can have something done. But if you have something done and the next day wish you had, you can't go backwards.
Yeah, you can't go back. And that's it's a tough thing, but I'm glad we got these guys enlightening us. I mean, this is something I don't see every day in family medicine, especially the surgical stuff. And so it was informative for me, and I hope our listeners enjoy it too.
Have you ever had a patient in your training request something like this?
There's a lot of folks that I've got to care for that talk about and start and toy around with the idea of transitioning as a blanket term. But even apart from medical science and the standard of care, individually, that means different things to these people. And I think a lot of folks like the idea of doing some of that without going whole hog, so to speak. Mm-hmm. So I've never, it's still new enough, I've never had the opportunity to care for a person who's gone all the way. But I've definitely heard from these folks, and it's only a cursory literature search and Google search to see folks who really regret doing this. And that's why so many of the places that pioneered it, a lot of the countries in Europe, Northern Europe especially, they've stopped doing it.
Except as part of a study.
That's right. Yeah. So at least they're calling it experimental, but it's not the standard of care anymore. And even a lot of folks who are pro-transitioning, pro-gender affirming care, they're coming out and saying, we shouldn't be rushing into this. And a lot of people do regret it.
Yes, which is good to know. Which brings us to the medical trivia question of the day. The category, of course, is the urethra. You didn't see that coming, did you? So, the urethra being that which carries the urine from the bladder to a receptacle outside your body. So, question, Dr. Oliva is going to talk about the urethra. In women, the average length of the urethra is about 4 centimeters, just over 1.5 inches long. What is the average length of the urethra in men? You're going to have to wait till the end of the show to find out, but we'll be back with the 2 interviews from Rome shortly after this break on Dr. Doctor. We're recording in Rome at a conference of the International Association of Catholic Medical Associations called Medicine. Is it reparative or is it transformative? And one of the speakers here is a previous guest on Dr. Doctor. It's Dr. Paul Hruz from the Washington University in St. Louis, where he takes care of patients and does research in pediatric endocrinology. Paul, welcome back to Dr. Doctor.
It's my pleasure to be here.
So a different angle on the transgender topic today, and that is sports competition. I think this is going to fascinate our listeners. And I think we should do an overarching thing. The Catholic Church has said many good things about sports over the years. Why would they do that?
Well, certainly there are many benefits in athletic competition that are well recognized. Building self-esteem, the effort that's required to excel in athletic competition that can lead to very important lessons for our children, and that will carry them out throughout life. So certainly that we know that there's incredible benefits with allowing individuals to compete in athletic competition.
And something called Title IX was passed years ago in the U.S. What does that do?
Well, it wasn't specifically directed to sports, but that's how it's best known currently. It had to do with more generally as far as making sure that both sexes had equal access to education, and in its application to athletic competition. Prior to Title IX, very few females were competing in athletic competition.
In college or high school.
Even in high school or college. And this really leveled the playing field and allowed the entry of females into athletics, and really just exponentially increased the participation of females in that area.
Very good. Do you do any sports, or did you?
I did. I actually wrestled all the way through college.
Oh, so, one of those. Yeah. There was this family. They had like 7 boys, good Catholic family. They were all a lot shorter than me, but the minute you walk in the house, you were on the floor. I mean, they were wrestling you, and there was just didn't have a chance. I really. And then one day, the wrestling coach said, "McGovern, come try to make it through a practice." I made it through, but barely. You guys worked hard.
It was true to the benefits as far as lifelong lessons that were learned, as far as the necessity to sacrifice, to be able to dedicate yourself in practice, and to overcome adversity. That when you don't win every match, and you have to learn how to deal with that. So I benefited in many of the ways that I described earlier.
Excellent. So, is there a difference biologically between men and women, boys and girls?
Most certainly, there is a difference, and the differences in the bodies are very apparent to anyone that takes a moment to look at that. And this is going to be very important when we discuss the topic of sexual difference in athletic competition.
Sure. So, what are the differences? We'll take college age, for instance, because college age in International Olympics, that's where this question has really come to the fore. I suppose it is in high schools also. But is there a competitive advantage of one sex over the other?
We see this throughout life, but certainly most strikingly after individuals have gone through puberty. And the differences relate to differences in bony structure, in respiratory capacity, in cardiovascular function, in muscle strength, muscle mass, all of these components that are essential to competing in various athletic competitions.
And do these all favor male, or are there some things that favor females?
Certainly females. When we look at muscle fiber type, when we talk about fast twitch versus slow twitch muscles, there are some female components where the muscle type actually favors more distance running. However, that is together with the other elements that are necessary in the various competitions. So counterbalancing that, things like hematocrit or red blood cell count that gives you oxygen carrying capacity, your size of the heart, that how effectively that it can contract and deliver blood to the tissues that need it during exercise, respiratory capacity as far as how much oxygen that you can breathe in with every breath, that will make a difference. So that there are components of this, but taken as a whole, there's the competitive advantages for the male.
So what are some of the ones for female? Like I've heard ultra distance running, like past marathon. At what distance do women do better than men?
Well, as far as if you look at across the board, and this is the data that's actually used, is if you look at Olympic records in various sports and the differences between males and females, I think across the board, the percentage differences will vary between the competition that you're talking about, related to some of those intrinsic differences in what is the component of that, the difference between males and females that are necessary for that. And so the differences in running competition is smaller, about 10%. And the difference so if we look at the competitive advantage for a sprinting event versus distance, it's smaller, less than 10%. As opposed to weightlifting, where it's a 50% difference between the two different sexes.
And then I'm thinking certain types of gymnastics favor women more, don't they?
And that has a lot to do with body size, weight, and together with some of the coordination elements that are not as directly related to musculature, more balance, for example, and being able to compete in those
So we're
areas.
probably not seeing many biological men competing as women in gymnastics, I would guess.
I have not seen it myself, no.
Very good. So why is there a difference in female and male body? It's all testosterone, right?
Well, it's not to discount that testosterone or sex steroids in general are a major contributor to this difference in athletic performance, but there's certainly many other components that are independent of the sex steroid hormones. And so that's where, it's very important to recognize the hormone independent effects, which actually relates to genetic differences between males and females.
So is it because men don't have two X chromosomes, or is it the Y chromosome, or what makes the difference then genetically?
What we do know about the genetic contribution, again, if we look at athletic performance differences in pre-pubertal children prior to the time of going through puberty, we know that there are differences in what we call epigenetics, so that it's beyond just the X and Y chromosome. By being male or female, there are structural differences in the DNA itself, where the DNA gets modified to direct differential expression of the genes that make the proteins that carry out all the instructions for the body. So those differences are present very early in life. There's data that there are over 6,000 genes that there's a sex differential expression, meaning that if you look at one gene versus another in a male or a female, they're different.
Oh my goodness. So even though they might have the same sequence, they are activated more or less in men and women than in the other sex.
That is correct, and we very well understood these differences. It's the same reason why there's different disease susceptibility.
Yes.
So there's different responses to medications between males and females. Yes. It's another example of the exquisite difference that's present. And it's necessary to consider those differences when we want to understand the function of tissues, muscle. Males and females differ in lean body mass, for example. Now much of that is driven by sex steroid hormones, testosterone or estrogen.
Sure.
But beyond that, there's also genetic contributors.
So this epigenetic, to me, it's this big nebulous black box term. What is it that turns on some genes and not others? What are these epigenetic factors?
Well, two main ones that I will mention in this conversation. It's called histone acetylation and DNA methylation. So these are chemical changes that occur to the DNA that change the way the instructions are read by the body. So when we think about DNA, DNA is merely the instruction book for the body to know what it's supposed to do. And there's machinery that's necessary to be able to read that information and then translate it into the signals that do all of the work. And because of these epigenetic changes, it alters the way that the body reads those instructions. And that's why we see differences in gene expression.
And this is regardless of hormones or partially due to hormones?
It certainly is. Hormones will have an influence on this, but we do see differences that are independent. The best data that I can share with you, there have been experiments that have been done, what we call in vitro, within the laboratory setting, within a petri dish, where you take cells from a male or a female, and then you look at the genes that are expressed. And this is in a setting in which there are no hormones there at all. And in those studies, those differences that I mentioned are present as far as some genes that are expressed more and less, just by virtue of the fact of whether it's a male or female cell.
So let's go to, it's not an experiment of nature, but it happened through some horrible things. So in the Bible, it talks about eunuchs. Those were males whose testicles were removed before they went through puberty. How would they have been physically, physiologically different than a woman?
For the same reasons that we've just talked about, the differences that most people recognize, having not gone through puberty, they don't have the lowering of the voice, they don't ever have the virilizing effects of the testosterone, so that facial hair is absent.
Sure.
But the genetic differences are still there between the males and
So
females.
would eunuchs still have a competitive advantage over females in many sports?
Well, I'm not aware of the science that has looked at eunuchs per se, but I can look at the data when we compare, for example, the differences in prepubertal children. So
Yes.
that before they go through puberty, if you look at fitness tests, and this has been done in several different countries over many different time frames, and looking at individuals of different levels of fitness, and consistently these male-female differences are present. So you can't attribute it to the testosterone that at that point in life, these
Right.
children have never been exposed to that. So it really indicates that there are differences. The differences actually do become much more significant after puberty, but the important point is that they're there prior to puberty.
So what are some of, you mentioned, off recording that bone length differences make a difference. What does that make a difference in?
Well, again, it's dependent on the athletic competition that we're talking about. But as an example, the ability to throw a baseball, this is one of the areas that there's one of the greatest differences, almost 50%. And so there's a general physics. If you look at the motion that the arm has to go through and how that affects the velocity of the release of the baseball, is going to be very different depending on bone length. Stride length is very different in the legs based on that. When we talk about respiratory capacity, there's lung volume, but there's also differences in the ribs, for example. And then probably most significant when now this is more post-pubertally, when we look at the shape of the hips and how that actually
sure.
will contribute to the mechanics of how
running.
one runs.
Now, you're saying in baseball, but it seems to me that women's softball pitchers, which is windmill underhand, they're just about as good as men and just as unhittable.
So this illustrates perfectly, that the basis of what we're talking about. Because if you think about the physics that one needs to have, and that's very likely the reason why that sport evolved, and in females pitching the ball in that manner is to take advantage competitively in the best way for the giftedness that the female has.
And it's actually a lot easier on the shoulder, a lot less injuries than throwing a baseball overhand. They don't need Tommy John surgery. So now the big question, of course, is competitive sports. So say a biological male wants to compete as a female. What are the current rules that the NCAA or the International Olympic Committee have come up with?
It's very interesting when we look at the regulatory requirements, and they've evolved over time. And right now, the focus is based primarily on lowering testosterone levels, and there's been debate about how low they have to be decreased. And how long they have to be decreased to be able to level the playing field. And there is a clear drop in athletic performance when one lowers testosterone levels. But the question that one needs to ask, does it get to a level that essentially is equal?
So do the levels have to be the same range as a normal female testosterone level?
Well, that is the argument that the Olympic Committee and the NCAA have adopted, with the argument that if we lower the testosterone levels of a biological male to that which would be seen in a female, that would level the playing field.
But they're not really following the science. It doesn't level the playing field, does it?
In no way does it. And there's actually over a dozen studies that have shown consistently in various measurements, looking at the net effect. And so there is a lowering of athletic performance, but there's a residual gap of athletic advantage that ranges anywhere from 10 to 30% after the testosterone is lowered. And when they've looked at that, and again, some of these studies have been done between 1 and 3 or 4 years at most that I've seen, that when they look at each of the different parameters, so the ability to extract oxygen, the muscle strength, or the whatever the measure is that you have, it will vary. But across the board, there are residual differences that are present.
So in other words, these organizations that say they're committed to equality among the sexes are really now discriminating against women.
I would say most certainly they are. And another way to look at this, so that if you look at the most elite female athletes in several sports,
yes,
there are literally thousands of males that surpass that Olympic record.
Oh, sure.
And that even after the lowering of the testosterone levels, you're going to see that competitive advantage.
Where do you think this is heading? Are there any countries that are saying this is nonsense? We can't do this.
Well, they're certainly in our cultural conversation right now. They're trying to balance two different goals. I think that we're seeing this, and the whole topic of athletic competition is really touching a nerve within our country, and I think in other countries as well, because of two issues: both fairness,
yes,
but also safety. We haven't touched on that either. That there are safety issues as well, and balancing that with the desire to be inclusive, so that there's a desire to say that the desire to be able to include people that have sex discordant gender identity and being able to compete within athletic competitions according to their identified gender takes precedent over these issues of safety and fairness. The discussion actually is a good one to have, so that many athletes that excel in any sport will often have a competitive advantage that they were born with. Think about Michael Phelps. He had differences in his body shape that actually gave him an advantage. And so there is room and a necessity, to have that conversation. And where there's disagreement is where you draw that line, and whether you're doing this naturally or artificially. The other area, that is being discussed, and actually prior to this current movement of sex discordant gender identity or gender dysphoria, we saw this in the area of disorders of sexual development. So there's striking statistics about an overrepresentation of female athletes that have polycystic ovarian syndrome.
Oh, sure.
So
testosterone effect.
Higher natural levels of testosterone that gives them a competitive advantage. And there's been efforts to necessitate, when you exceed a certain level, to lower those testosterone levels.
Oh.
And then there are some cases of partial androgen insensitivity, or other, adrenal hyperplasia are the other areas where you can have differences in sex steroid hormone levels that will give a competitive advantage. And so there's much that needs to be discussed about this, but we need to recognize the way it's being presented in a very simplistic way of saying it's all testosterone, and that there is a possibility of having fair competition is not borne out by the science. In fact, it strongly, almost definitively disqualifies that as a rational argument.
So ideology is trumping science.
Absolutely.
So last question, if listeners want to follow this topic, what sources are reliable?
Well, I'm sure the listeners aren't going to have access to the extensive scientific literature that's out there. Most of my colleagues in the field of medicine are not aware of the literature that's available. But I think that there's a need, as we continue on this conversation, to be able to at least recognize, as we're doing here in this interview, to be able to reference that. There's really very little information that is generally accessible to the public at the moment on this topic, and that's why it's wonderful that we're having this opportunity.
Great. Paul, thanks for being with us again on Dr. Doctor.
My pleasure.
And we are still in Rome at the International Congress of Catholic Medical Associations, where we have Dr. Al Oliva from Spokane, Washington. Al's a plastic surgeon that's subspecialty in microvascular plastic surgery, and he spoke here about surgery and surgical complications of transgender surgery. Al, welcome to Dr. Doctor.
Well, thank you very much, Tom, for having me on your show.
Oh, it's a pleasure. So you talked about these mutilating procedures that are being done on people. I can't think of another word to use to describe it. What is the landscape like right now? How often are such procedures being done to convert a biological male to look like a female and vice versa?
Well, the numbers and the procedures may be hard to come by, but we know that approximately 0.5% of adults are seeking transitioning. And so for some, it'll just be hormonal treatment, and for some, it'll begin with surgery. So for women who want to be men, typically that includes a mastectomy, and then they continue on hormonal treatment. And then for women who want to become men, it's very, very difficult because to create a new phallus, you have to use another body part, usually the forearm, which is made into a tube.
And we'll talk in detail about that later. And then the other direction?
The other direction is a bit easier because it includes a penectomy and then use of the penis and the scrotum to create a new vagina. The complication rates are not insignificant, and in the female to male.
And we'll get into that in detail. So just want the big picture right now. And I think one of your slides talked about an incredible increase in the last 10 years of people identifying. How big has that been?
Well, the CDC says it's a 20 to 40% rise. In
40 times.
40 times. Yeah,
not
40
just percent.
Times, right.
Yeah.
Rise. And so, and the change that's occurred is traditionally transgender children were boys, prepubescent boys, and it was a very small percentage. Now it's post-pubescent girls.
Yes.
Reaching adolescence who now think that they're actually young men. And I think some of the theories include that this is a social contagion. There have been articles published on rapid onset gender dysphoria.
Yes.
And parents are bewildered because their little girl never had any signs of dysphoria, but then as they became involved in social circles where other girls were transitioning. They had some social status with that at school. It became a cool thing to do. And parents have noticed this large spike in young women.
Now, this surgery has gone by various names. I remember when I was a kid reading about, what was it, something Richards, Renee Richards, or somebody who had undergone transsexual surgery. But now there's been an evolution of terms.
Right. And I think that's a reflection of the surgical community embracing this as an ideology that should be promoted. And so we've gone from sex reassignment to gender reaffirmment, conforming, and now gender affirming surgery, as if this was the gender all along and the surgery is just affirming what that gender was.
Do you have any thoughts on why, you have a discordant psyche or mind or emotions with the body? And the assumption here is that the body is wrong, not the mind or emotions.
Correct. And that's the big fallacy here, that we're assuming that the body's at fault, where in actuality it's the mind that's at fault. The idea that you're in the wrong body has to generate an extreme amount of anxiety.
Oh, yes.
And which is dysphoria.
So the indication for the surgery is to correct the problem in the mind because they feel like they're in the wrong body. They want to have their mind in accord with their body. So how would one go out to measure whether or not these surgical interventions help the psychological problem?
Well, there are longitudinal studies, and for that we have to look at the Scandinavian countries where the surgeries have been performed for the longest period of time. So there's good data from the Karolinska Institute in Stockholm, Sweden, by Dr. Dine, and they looked at post-surgical patients who were at least 10 years after their surgery. And in that group, they found that the suicide rates, completed suicide rates, were much higher than their cohorts. So for men wanting to become women, it was 19 times, the suicide rate was 19 times the general population. But for women wanting to be men, it was 40 times the general population. So it showed that whether you have surgery or not, the surgery is not going to prevent a lifetime of dysphoria. What I'd like to add is that the surgery, in fact, may be very harmful because of the complication rates. So you've added surgical complications to an already debilitated psychological person or someone who's struggling with their identity.
So we already know that the treatment itself doesn't help the primary goal, the primary endpoint of a normal psyche. So if this was any other area of medicine, something to treat, heart attacks, and it increased them by 20 to 40 times, it would be stopped dead in the water.
I agree. The complication rates from the surgery alone and the level of evidence of the scientific studies, which are level 4 and 5, would
are the lowest.
Yes, which would indicate that these procedures should not be done.
Yes, weak or very weak evidence, if at all. Now, there's something that I learned about in dermatology that I'm sure you learned about in plastic surgery. It's called body dysmorphic disorder. Could you explain what that is and why you would avoid doing surgery on someone like that?
Well, it's a psychological disorder where one perceives a body part or several body parts or the entire body as being abnormal in some way. And so there's no congruence between the psyche and the body. And so we've always been taught to avoid operating on these patients or operate on them very carefully because their perception of what their outcomes are going to be may not be in line with reality. And they may become more confused, more traumatized by the surgery. In gender reassignment surgery, this principle has gone out the window. We now operate on people and not accurately assess their mental being before they have all of this surgery, which is irreversible and oftentimes fraught with complications.
So it sounds like gender reassignment surgery, whatever you're going to call it, is really a subset of body dysmorphic disorder.
It might be, but the issue here is that the DSM classification does not designate it this way. It used to be called gender identity disorder,
yes,
and now the designation has changed to gender dysphoria.
Right. So there's a group called WPATH, a World Organization of Transgender Health, and they have guidelines before somebody can undergo one of these mutilating surgeries. What are their basic guidelines before?
Well, the basic guidelines is you have to have informed consent, and that varies in countries. In the United States, it's the age of 18. And we can talk a long time about what informed consent is. Have you really informed the patient that these are irreversible surgeries, that they will be impotent, they will not ever be able to reproduce, that their sexual function will be completely distorted and may never have sexual pleasure. Right. So are those issues really involved in an informed consent? Beyond the informed consent, then you need to have been on transgender hormones for a year, and you've had to be living as the opposite gender for at least a year.
For at least a year. And yet they don't realize that, I heard somebody talking at the conference last night after you had spoken that, so say it's a man identifying as a woman. So if she appears as a woman, how many people out there are going to want to love her physically and emotionally as a woman?
Right. And that is the issue that I've been not able to find anything in the literature. But it just seems common sense that if a man is transitioning to be a woman, they're looking for a mate to be loved and to love, which is a normal cis man.
Right.
They're looking for that kind of a relationship. And so I haven't been able to find anything in the literature on what the success rate of that is. But I would think it would be very hard to find a cis man, a normal native man, that would want to have a strong binding relationship with a transgender woman.
Right, because they have become a shell, in some sense, of their former self. They're just an outward shell that has none of the function. So no matter what miracles, so-called, that you can do.
And the data is, not very, very clear either on, the sexual function of trans women, the ability to, to have intimate intercourse with vaginal reconstructions. There's a lot of problems with contracture and...
Yeah, let's talk about some of the surgeries. So you described a whole host of things that are done in a male to female transition, penectomy, making a clitoris. Tell us about all the things that can be involved there.
Well, basically, if a man wants to become a woman, you have to get rid of the penis, the scrotum, and create a new vagina. And the new vagina ideally would be 10 centimeters in depth. And there are various ways to do that. Using the penis itself, you destructure the penis and use the outside skin to make a vaginal vault. That's probably the most successful way. Other ways have...
Not that you would ever do any of these,
no,
to be clear.
I don't do transitioning surgery of any kind. I don't think it's... because basically it's not going to help patients. It has a high complication rate with very little benefit. So, and then the scrotum gets... the testicles get removed, and then the scrotum becomes the labia majora. So it's a complicated surgery fraught with complications.
And what are the complications? Besides, you said stricture.
Yeah, stenosis of the vagina. But wound healing happens to be an important complication. Along with the new urethra, there's urethral stenosis and stricture at the urethra. So the urinary component of the urogenital makeup of the human being is the most difficult part to reconstruct.
So even though you're shortening the urethra,
you can have complications with strictures
of keeping it open,
right,
so that you can urinate. So that might involve what, catheterization?
It might involve a suprapubic cystostomy for a period of time.
So wearing a bag to urinate into?
Right, if the complications are severe enough. So it's much harder to become actually a man if you're a woman, because now you have to lengthen the urethra, and that's where you end up with strictures and fistulas.
So first of all, let's finish up the male to female. You talked about that transgender chest surgery. They've done apparently hundreds of studies. You showed us a big number. It was in the thousands.
800 or so.
Okay, but in only 3.4% of them, they asked an important question.
Right. They asked about, and what is your psychological makeup now? The studies out of 890, only a small fraction of those were adequate enough to evaluate any outcomes. But only 3.4% of the studies actually looked at psychological outcome. And even in those, the data was obtained through questionnaires and self-reporting. So it wasn't that anyone actually interviewed the patient and said, how are you doing? And so the primary indication was for psychiatric well-being.
Yes.
But only 3.4% of the studies actually even addressed it at a minimal level.
At a poor level. In fact, you said that there was a huge review of male to female surgery, 1,300 studies. Only 40 had good enough evidence to even review, low evidence. And there was an astounding complication rate to form a vagina. Do you remember what that complication rate was? I think you quoted 32%.
Yeah, 32% is about the right.
And you said that if surgical complication rate is above, 20%?
I would think 20% is a high complication rate for most surgeries. You start questioning whether to do them unless it was for a life-saving
right.
reason. So if you have a complication rate of 20% in a purely elective cosmetic operation,
you wouldn't do it.
I just can't believe anybody would do that. Would you do 1 out of 5 facelifts that turned into a disaster? Would anybody do that? Certainly no one today does a cosmetic operation
with that,
with a 20% complication rate.
And then you said female to male is even harder.
Yes, female. This is the very hard one. Female to male, in a one study or one center study, which is important because then the techniques are comparable.
Yes.
In Amsterdam, had a 65% urethral stricture rate. So, and a 70% revision rate.
Oh my goodness.
So that's a very, very high complication rate. And
that's using that flap from the skin of the forearm.
Right. So the part of the urethra is native. The next part of the urethra is made from the labia minora. And then the third part of the urethra, which would be in the phallus, is made from the flap.
Wow.
And so where the connections occur in the reconstructed urethra is where strictures can occur. And they do occur, despite placing Foley catheters there for weeks and trying to stent open the coaptation.
It just doesn't work.
Just doesn't work.
And as I said, these people are a shell of what a male or female is. And this high of a complication rate, you're right. I wonder, are these people being informed about these problems?
I just don't see how anybody's providing that kind of data to them. I think there's an ideology that this is good for patients, that they're going to be happier. And who doesn't want to help a patient who's unhappy?
Right.
Right. What physician doesn't want to offer something? But we're offering a very false hope, a hope that, if you just go on and do these surgeries, life will be fine. You'll be who you should be. And it just isn't true.
And they're stopping these or putting the brakes on them in other countries, aren't they?
That's right. So if you look now at Sweden, Finland, France even, and Norway, their national health systems are starting to look at the data and obviously saying, is this where we want to reappropriate our resources? Are we helping our citizens by doing these surgeries?
So why are we racing behind them in the United States?
That's a great question. I think the powers that be aren't looking at the data or don't want to see the data that's reported. And unfortunately, some of the data that's reported reaches a conclusion that's contrary to the data.
Yes.
Yes. And that's become, for me, I think, a real eye-opener, something I thought I'd never see in medicine, that you would present data that shows A and then conclude that the data says B, and then other organizations are calling you on it.
Are there any sources that listeners can go to if they want more information on what we talked about?
I think a very good source for the layperson or professionals as well is the Society for Gender Evidence Medicine. It's SGEMs. And you can easily find it on the website. They have a lot of literature for the physician, but they also have basic content for just the average layperson.
Al, parting thoughts for our listeners.
Well, I think, I'm just saddened by the fact that I think we're living a lie in this part of medicine, that we have data that shows one thing and yet we insist on invoking our own prejudice. Certainly in medicine in the United States, gender identity is the gospel.
Right now it is the emperor's new clothes.
And anyone who doesn't embrace it or anyone that questions it has to be sanctioned or perhaps their privileges taken away. And that's the fear that I have for physicians of faith moving forward, that if they don't participate in these things, then maybe they shouldn't have a license to practice medicine.
But there are many courageous ones out there like you who are doing the right thing. And hopefully good will continue to triumph over evil. Al, thanks for being with us on Dr. Doctor.
Thank you very much, Tom.
And we are back with Dr. Doctor and the answer to the medical trivia question of the day. Tom?
Yes, the urethra in women is just over 1.5 inches long, carrying urine from the bladder to the outside world. But in a man, that 4 centimeters length is really 18 to 20 centimeters, 7 to 8 inches, which means it's 5.5 to 6.5 inches longer in a man than a woman. And that's what those surgeons Dr. Oliva talked about are trying to keep open in a woman who's trying to look like a man.
That's a lot of urethra to pull out of thin air, or the forearm in this case, which is kind of morbid. But, I think a lot of people will recognize that. I get to talk to folks about this in family medicine a lot as to why ladies get more UTIs than men generally, because the urethra is shorter and it's easier for the bacteria to get into the bladder and cause trouble there.
Exactly. And once it's in the bladder, it's kind of a closed system and it can grow without antibiotics being introduced. And once they are, then the infection goes away. So, Andrew, what are your top 3 from hearing these interviews?
Man, it was great. Kind of to split it up between the 2 interviews. Number 1, I would say testosterone's not the whole story.
Yeah.
Apart from what you'd hear about and read, the epigenetic sexual differences, especially the studies they talked about in kids before they go through puberty.
Yeah.
That has to be explored. I mean, I've got daughters. I know you do too. Women's sports, I think, is the example, but obviously there's so many other facets of life where this is really important to get right, not only for my daughters, but for the patients who are suffering with this, with gender dysphoria. So that'd be number 1. I'd say number 2, in regard to the surgical stuff, is the suicide rates.
Oh my goodness.
You can't hide from that. People should be aware of it. The suicide rates, they always talk about it as maybe because these folks are not made to feel comfortable or they're discriminated against. But even the surgical cure, the suicide rates go way up, something 20 to 40 times higher even after surgery.
Yes.
So if the surgery was supposed to fix that, it doesn't. It makes it worse. So that would be number 2.
And what other medical treatment would we continue in the face of that kind of data?
Yeah, no, you really have to. You guys mentioned the Emperor's New Clothes. I mean, that's the perfect analogy, and these stories are there for a reason because history repeats itself, and this is the newest example of that.
And number 3?
Number 3, I'd say if we want to be serious, I'm talking to all my scientific friends who think this might be a good idea. Let's follow the science. Dr. Oliva brought up a great point that the indication for these surgeries is a psychiatric indication, not a physical indication. But the outcomes of these surgeries, only 3% of them looked at psychiatric outcomes. So we're saying we're doing this surgery because of the dysphoria.
Mm-hmm.
Just, 3%, we actually look to see if the dysphoria gets better. Is it because we're doing a bad job, or maybe people don't want to know, or maybe they do know and they're not studying it because it doesn't support the cause? So let's follow the science. That's what I'm all for.
Amen, Andrew. Great way. I'm glad you got that out of it, not having been there, because I was similarly, I don't know, affected by them. They were pretty dramatic. So that brings us to the end of yet another episode, and we thank you for being with us. You can find this and all old episodes on our website, drdoctor.org. Just click on Episode Archive at the top, where you can search over 290 episodes by topic or guest.
And now we even offer a video version of our podcast. Just click on the YouTube link near the top of our homepage at drdoctor.org. And if you have a question or an idea for an episode topic, click where it says Submit a Question.
This is Dr. Tom McGovern.
And Dr. Andrew Mullally, and we're signing off until your next dose of Dr. Doctor.
The views expressed on Dr. Doctor do not necessarily represent those of your co-host. Have a question for our doctors or a topic you'd like to hear about? Call or text your questions to the Holy Cross College text line at 260-436-9598 or fill out the form at drdoctor.org. Follow us on Facebook and Instagram at Dr. Doctor Show and tune in for new episodes every Friday. Plus, find all our past episodes at drdoctor.org.